Next, we have an endovascular repair in patients with heritable thoracic aortic disease by Dr. Solomon from Washington University School of Medicine in St. Louis.
Good morning, everyone, and thank you for coming. My name is Julie Solomon, and I am a third-year medical student at Washington University School of Medicine. Today, I will be speaking to you all about the research I conducted with Dr. Wesley Oman and Dr. Alan Braverman. Thank you to VESS for the opportunity to present on the short and long-term outcomes of endovascular repair in patients with heritable thoracic aortic disease. As many of you know, heritable thoracic aortic diseases, heretofore referred to as HTADs, are a collection of syndromic and non-syndromic conditions wherein the molecular structure of a person's connective tissue is less durable than the norm. The syndromic conditions include Marfan syndrome, Loeys-Dietz syndrome, and vascular Ehlers-Danlos syndrome. People with these diseases, as well as non-syndromic HTAD, may develop a multitude of degenerative processes, most notably aortic aneurysms and dissections. The vascular complications of HTAD are the primary cause of death in this population. Thus, current guidelines have declared preemptive open aortic surgery as the standard of care for people with HTAD who have degenerating aortopathies. However, within the past several decades, surgeons have developed and mastered endovascular aneurysm and dissection repair techniques in the general population. This has sparked recent interest and debate as to whether endovascular repair may also be feasible in patients with HTAD. Endovascular repairs are thought to be less morbid than open surgical repairs. However, placing a stent graft requires continuous outward radial force against the blood vessel, particularly at the proximal landing site, and there is concern whether the fragile vessels of HTAD patients can withstand such force. Thus, stent grafts are currently reserved for high-risk cases and life-threatening emergencies when open surgery may not be timely or feasible. Unfortunately, there is lacking evidence on the outcomes of endovascular repair in HTAD patients. Thus, we examined cases in which endovascular repair was used at our home institution to evaluate the validity of the current school of thought. We retrospectively gathered data on the clinical features, imaging characteristics, and short and long-term outcomes of our selected patients. To be selected, patients must have had a genetically or clinically confirmed HTAD, undergone at least one endovascular or hybrid procedure at any institution, and be followed at our home institution. We found 29 patients who met our criteria, and those patients underwent 37 distinct endovascular procedures between 2006 and 2020. To our knowledge, this is the second largest case series to date. Just over 50% of our cohort was male, and the mean age at the time of intervention was 45 years old. Most of our cohort had Marfan syndrome or Loeys-Dietz syndrome, with just a few having non-syndromic HTAD or vascular Ehlers-Danlos syndrome. Acute and chronic aortic dissections were the most common indications for endovascular repair. Of those who underwent repair for a degenerating aortic aneurysm, the average maximum diameter was 51.8 millimeters. Around 2/3 of our cohort had a proximal landing zone in their native vessel. Given the concerns over outward radial force in this population, oversizing was conservative at 11% on average. For the remaining 30% that had a proximal landing zone in a prior surgical graft or elephant trunk, the oversizing was more substantial, at 25% and 23% respectively. Distal oversizing is less crucial than proximal oversizing for securing the stent graft in place. Thus, for the 86% of patients with a distal landing zone in the native aorta, many surgeons opted for no oversizing, and those that did oversized highly conservatively. The average was 2%. For patients whose distal landing zone was in a surgical graft, the oversizing was high at 43% on average. Our patients were followed for an average of 4.5 years. All procedures but one were deemed technically successful. The exception was unsuccessful due to an irreparable kink in the stent graft. No procedures required open surgical conversion, and no patients died within a month of their procedure. Of the 2 deaths, one was a patient with Loeys-Dietz syndrome who died of a central line-related staph aureus septicemia 33 days after their procedure. The other death was in a patient with vascular Ehlers-Danlos syndrome who had an acute type B aortic dissection complicated by aortic rupture. Following emergency endovascular repair, Pseudoaneurysms developed at each prong of the endograft. He was deemed unfit for open aortic repair by vascular surgery and died 116 days after his TVAR, presumably due to subsequent aortic rupture. The combined total short and long-term outcomes are listed in the table, with the medical outcomes at the top. The direst outcomes were 2 procedures complicated by stroke and 1 complicated by paraparesis. Of note, no patients developed spinal cord or bowel ischemia, so these outcomes were removed from the table. The bottom half of the table contains the surgical outcomes. Of the 34 procedures with the native aorta as a landing zone, 18% resulted in signs. 2 of the signs were proximal and 4 were distal. 16 endografts, or 43%, developed an endoleak, approximately half of which were type 1 and half of which were type 2. 46% of procedures required reintervention, the majority of which were not required for more than 1 month from the time of operation. We compared our data to the 14 other case series in the literature examining outcomes in HTAD patients after endovascular repair. As you can see at the bottom of the table, our study is the second largest to date and reaffirmed the existing data, with all of our outcomes falling within the reported percentage ranges. We also compared our data to the recent GENTAC study examining the early and late outcomes of surgical repair in HTAD patients. For those who aren't familiar, GENTAC is an alliance formerly powered by the NIH that curates an expansive registry of HTAD patients and their outcomes. Our study showed fewer early and late deaths, as well as early reoperations. Given how sick our population was at the time of operation in order to warrant an endovascular repair, this comparison heavily implies that endovascular repair can be both safe and stabilizing in patients with HTAD. However, the late reoperation risk was much higher in our cohort, demonstrating that surgical repairs remain the most definitive treatment by a large margin. Thus, our conclusions are as follows. Endovascular repair may be performed at low risk in selected patients with HTAD experiencing acute and chronic complications of aortic aneurysm or dissection and branch vessel complications. The risk of endoleak signs and repeat interventions after endovascular repair in HTAD is high. Endovascular repair may reduce short-term mortality and morbidity, but it is often not a permanent solution. Furthermore, we would like to stress that endovascular repair is not the standard of care in patients with HTAD and should only be done in a multidisciplinary manner by experienced endovascular aortic surgeons. Lastly, we would like to thank the people and programs listed here.
Thank you, great job. I just have a couple of questions. As you mentioned, the standard of care for these patients is to treat this patient open, and I think when some physicians decide to treat these patients with endovascular treatments is because of the acuity of life-threatening situation at that time. I may have missed it, but did you mention that these patients were treated either at an outside hospital and your institution and not just from your institution, correct?
Correct.
So we don't know exactly what sort of bias or decision-making was made on those that were not treated within your institution, correct?
Correct. In our review of the charts, we can certainly confirm that every patient was in a fairly acute, probably life-threatening situation at the time.
Got it. And then the high risk of reintervention, did you look into what kind of interventions were done? Were they also endovascular? Were they converted to open? You have kind of analysis of that?
Yeah, most of them underwent at least one other endovascular intervention, and quite a few of them also underwent an open reintervention.
Okay, thanks. Dr. McGee?
Yeah, I actually wanted to follow up on your questions too. So congratulations on your talk. I kind of interpret this as a cautionary tale. It sounds like with nearly 50% reintervention, clearly that's not ideal. And the thing about connective tissue disorder patients is they're typically very young. So most of the time they can tolerate an open operation. So my question to kind of piggyback on that is, what is the underlying confounders that led to them getting this endovascular intervention in the first place? And perhaps something to be learned from that. I mean, if, like you said, if it's just a bridge to something else, I think that makes a lot more sense. And that's really important when you're writing your paper and how you're drawing your conclusions, because I think, as you said, it was safe, but I'm not sure it's safe in all patients. So those are my questions.
Yeah, thank you for your questions. I'm not quite sure I understand what you want me to speak to.
Why did you choose endovascular intervention in these patients?
Oh, yeah, so I think that's kind of similar to the earlier question. Most of them were deemed unfit for surgery, at least at that time, by vascular surgery due to being unstable. There was a minority of patients who I believe opted for endovascular repair in the setting of an enlarging aneurysm. But for those patients, I think it was their personal choice after discussing with their physician.
All right. Well, thank you.